Good morning. Now, I think we're ready to begin.
We are, my lord, with Professor Craig Williams.
Professor. Good morning. Good morning. Now, Professor Williams, as you know, you're about to be asked questions by Mr. Connell, who's sitting opposite you. But first, I understand you're prepared to take the oath.
Yes, I am, my lord.
Sitting where you are, could I ask you to raise your right hand and repeat these words after me? I swear by Almighty God.
I swear by Almighty God.
That I will tell the truth.
That I will tell the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Thank you very much. Now, Mr. Connell.
Good morning, Professor Williams. I think you have a witness statement that was prepared for the inquiry. Are you content to adopt that statement as your evidence here?
Yes, I am. I have seen some documents and emails since I prepared the statement, which will hopefully allow me to clarify some of the areas in the statement, but I'm happy that this statement is accepted.
Thank you very much. I will, as I go through your evidence, I will tend to use in the main your statement as a guide to where we are at particular points. Okay. By all means, if there's something that you're asked about and you feel the need to add something else, please just do so in response to an appropriate question. Can I just check, you were employed by what became Greater Glasgow and Clyde Health Board from what, 2002, is that right?
Yes, I started at York Hill Hospital as a consultant microbiologist in 2002.
And you ultimately left, my note simply says in 2016, was it March, can you remember?
I think it was April when I finally left, March, April.
March, April of 2016. So your involvement in the issues that the inquiry is concerned with really covers the period up until that date. Before I turn to your statement, I wonder if I could ask you rather more generally about one or two things, if you don't mind. One of the things that you say many times in your statement, and others have said similar things, is that you seek information. And let me just use as an example the ventilation validation certificate for Ward 2A, and I'm just using that as an example, from something called the project team. And you don't get what you've asked for. You don't get the certificate. Now, I wonder whether from your experience with the board, you can help us understand this at all, because from an outside perspective, it's very odd that some reasonably significant players are saying, just give us that document, please. And it's just not happening. Can you help us at all as to how that actually worked?
Yes, so the validation that I think we were all referring to was part of the HTM 0301 process, whereby the buildings as a whole are reviewed by a group of expert external engineers who ultimately look at the totality of the systems and how they work together and come on the basis of a very long and complex report to a conclusion.
Well, I think we know we've heard from other witnesses what the technical meaning of validation was. What I'm keen to see if you can help me with is how does it come to be that part of the board is saying to somebody else in the board, give me this information, give me this material, and people are just ignoring you?
They weren't ignoring us, they were reassuring us that the validation had been complete and was, as far as they were concerned, completed. That occurred in a number of ways by email. I think a member of the project team attended one of the acute infection control committee meetings at the request of the infection control team to basically bring us up to speed as to where we were. So we were being reassured throughout the entire process that the validation had been done and we had nothing to worry about.
Well, I understand your point about reassurance, but in a number of places in your statement, and a number of places in the statements of lots of witnesses, people are saying, we went to try and get the validation certificate for whatever ward they were interested in. We asked the project team, we never got it. That's the kind of thing that you say in your statement at various points, and we can go there if need be. Now, how does it come to be that that happens? That you're saying, give me the validation certificate, and somebody is just not giving you it.
I don't know. We wouldn't normally have seen the validation certificate as such. We would have seen basically the summary of the validation certificate. And the summary of the validation certificate was being relayed to us by the project team, who were saying the validation has been performed and it's okay.
When you get that kind of situation, when you say, I want to see, the evidence, I want to see something, paperwork, whatever you want to call it, whether you would understand every technical engineering detail or not, doesn't matter, but you want to see the paperwork. Should you not escalate that, to somebody who can grab this person by the ear, bring them in and say, hand over the certificate now?
I mean, it was escalated on a number of occasions through the Board Infection Control Committee meeting. You can see in a number of the minutes that we're saying that the validation is awaited. The validation is awaited. So it was raised at the Board Infection Control Committee, which is basically the top of our escalation.
And still, someone else in the board was not producing it.
Yes.
And do you remember doing anything about that unsatisfactory situation where people were being asked to produce stuff and not producing it?
As far as I was aware, it wasn't an unsatisfactory situation, because if there'd have been any suggestion that there was any problems with the validation or that the validation hadn't been done, then that would have been something that would have needed a detailed follow-up. The fact that we were being reassured by colleagues in the project team that the validation was there, it had been done appropriately and had been done to the appropriate standards, we accepted their assurances that this had been done.
When you say colleagues in the project team, because one of the issues that this inquiry has is that people generally say, we asked the project team, as if it was some kind of individual. Was it an individual or more than one individual that you were contacting?
I think it's a number of individuals. I think there's an email from Jackie Stewart to one member of the project team. There were other members of the project team mentioned in Board Infection Control Committee meetings, so they were individual members. There was no generic project team as such. It wasn't just sent to a kind of generic email box.
Do you remember anybody in that team who gave you an assurance about validation?
There is an email to that effect, but I can't remember the name of the individual in the email.
Mm-hmm. The reason I'm asking that is that it looks a bit odd from an outsider's perspective that part of the board is saying to another part of the board, give me this information, and it's not, people are giving assurances, but they're not producing the goods, they're not producing the certificates. I mean, in fact, at one of the board committee meetings, we can look at these in due course. Somebody even suggested, if I have the note right, why don't we write a letter to David Loudon, who was the project director, I think. Do you remember that?
I remember writing to David Loudon about the episode around the validation, the use of the PPVL rooms prior to the hospital opening, but I don't remember people suggesting we write a letter to David Loudon about the validation prior to people moving in.
I'm just trying to understand this in general terms, Professor Williams, because when we come to look at your evidence, you start to tell us about going into various wards and discovering things that simply aren't right. Tiles not hung properly, obviously no HEPA filter, stuff like that. And musing to yourself, well, how could something possibly have been validated, as we understand that term, with that state? Which must have made you think, this is all very odd if I'm being told, oh yes, it's all been done, but I'm finding evidence otherwise.
Yes, it was very odd, and it was difficult to see at the point we actually got into the hospital and could see the lack of things like HEPA filters, that the validation could have been either done or passed. I don't know whether it'd be helpful to draw an analogy. I mean, the lack of a HEPA filter in one of these rooms, to take an analogy of picking a car, for example, up from a car dealership, is not like there being a scratch on the dashboard. It's like going to pick the car up and there's no wheels on the car. And these are basically fundamental problems with the rooms. So as soon as we accessed the hospital, it was pretty clear that there were fundamental problems in a number of the ventilation systems.
Which suggests that the assurances that you were being given that validation had been done were, to put it no higher, not accurate.
That would be the conclusion that I would draw. And I think there's also one or two emails from estates colleagues who actually highlight individual tests within the validation that should have been performed that we subsequently found hadn't been performed. But at the time we took the new hospital, I think this view was reflected by some of my colleagues. I mean, Dr. Peters, I think, said we expected better. I think Dr. Inkster will say it was a brand new hospital. We didn't expect any of these problems. So we were basically, over a period of about 4 or 5 weeks, hit by pretty much a juggernaut of problems with the ventilation systems.
So it's probably it's an interesting phrase of yours, hit by a juggernaut of problems. Might suggest that anyone who says we expected better from a brand new flagship hospital would be correct. Absolutely, yeah. Okay, let's leave validation for the moment, Professor Williams. We'll pick up in your statement where you touch on a number of these issues if need be. Let me ask you another general question, if I may. Now, this is about the way that infection control was or was not involved in the hospital build and design. Now, I'm going to ask you a number of detailed questions as we go through your evidence about that. But I'd like to take this generally, first of all. If I simply take, for the purpose of my question, that you say, well, I was not the person responsible for signing off on the ventilation design of the Queen Elizabeth Hospital, which is a paraphrase of your position, I know, but just take that for the moment. I wonder if I could ask about this. We've heard from various witnesses about the idea that infection control should really be at the heart of a hospital because of its importance. If the idea was that infection control should be at the heart of everything, would you agree that it would be sensible to put in place some significant involvement by someone with an infection control hat in the process of designing and building the hospital?
I think there was involvement of people with infection control experience throughout the process. At the beginning, I think the original specifications at high level were drawn up by Annette Rankin, Dr. Redding and Dr. Hood. And Jackie Stewart, the nurse consultant, was appointed to the project team, so there was a continuous presence of somebody with infection control experience. There was no expectation that one individual would have knowledge of all the complex systems which go into design a new hospital. So the nurse consultant role was as a conduit between the project team and the infection control to allow any questions to be raised and appropriately answered. There was actually infection control involvement from the beginning of the project.
Well, I understand that there was an infection control nurse who was allocated that role, but I'm thinking more of how, if you were trying to plan this properly, you might ensure that not just queries were answered, but somebody was overseeing and ensuring that infection control was built into every stage and every discussion. And you say, well, one person wouldn't necessarily have all the knowledge. And I understand why you say that, and you make the point in your statement at various points that you didn't have engineering expertise equivalent to what was in for instance, your estates colleagues. But would it not have been sensible to have somebody allocated to lead and coordinate infection control input into all of these exercises, calling on other expertise as required, as circumstances allow? With the benefit of hindsight, would that not have been a good idea?
That was the case, because that was the role that Jackie Stewart, the nurse consultant, was supposed to have in the process. And in terms of the documentation around the SHFN 30 for large builds, there is a clear section in that document which outlines the responsibilities for undertaking the HI scribe process stages 1, 2, 3 and 4. And it relates to the project sponsor appointing somebody to be responsible for signing off those documents. And I think it's the project manager who in that documentation has the responsibility for undertaking that role. Infection control's role in the document is advisory, supporting. The actual authority to sign off those scribes is delegated, and I think we may well come to it later, to, I think it's the project manager in that document, SHFN 30.
Does your answer, I think, suggests that the role of infection control wasn't playing as significant a part as might be thought desirable? Is that not fair?
I think from our point of view, the infection control input was as we were requested and as it was outlined in the documentation. We had a continuous presence of a nurse consultant. But at the beginning of the process, there was a lot of questions asked, which we largely dealt with by Dr. Inkster, Sandra McNamee and myself, in terms of sanitary fittings, taps, things like that. The specifications for the original build of the hospital were clear in the guidance in terms of what should have been provided in terms of ventilation in the HTMs and SHTM and SHBN 0401. So at the point of inception of the hospital, then the guidance covered all of the essential features of the hospital, and the level of the detail would have been provided by the guidance, not by individual members of the infection control teams.
And who was responsible for making sure the guidance was implemented?
That would be the project team.
Well, but the project team aren't focused on infection control. They're focused on getting the job over the line, aren't they?
Well,
Do you not need somebody to make sure infection control is dealt with?
The project team were responsible in the SHFN 30, and infection control was part of the project throughout, from the inception, from the early days of Dr. Redding and Hood through Jackie Stewart, with communications as required from the project team through ourselves, and then ultimately ending in my involvement after the decision was made to move the bone marrow transplant unit and the ID unit into the hospital tower.
Yeah, which comes a little later in the sequence. Part of my reasons for asking these questions, apart from trying to think of how things could have been done better, which is always something that an inquiry does, is that the value of having somebody senior in infection control keeping an eye on, overseeing, kicking, pushing, whatever needs to be done, might have led people to think that if you were the lead ICD, you must have been doing that, but you say you weren't.
No.
Can I just ask you a couple of related questions? I suspect I know the answers to these, so, but if you don't mind, I'm going to ask you anyway. Am I right in thinking that you had no detailed involvement in the negotiation and agreement of the construction contract between the board and Multiplex?
Yes, that's correct.
That's correct. And did you get involved in discussions about precisely what Multiplex were contracting to deliver?
No.
Thank you. Can I ask you now about another point I think you were aware was going to come up, have thought about a little. Am I right in taking from your statement that you're not a great fan of constantly sending emails to people with lots of detail on it. That's not your style.
I wouldn't say that. I think the the number of emails needs to be appropriate to the conversation that you're having and the communication that you want to have with people. So on some occasion, it's necessary to send very clear emails. And I think, again, there's examples in the bundle when I was trying to communicate with the project team about the need for clarity around what guidance was being applied to the PPVL rooms in the tower. There was a very clear statement of what I was asking. In other emails, you're responding to a conversation or a very short previous email where people are just asking for some clarification or for your brief opinion, in which case the email will vary depending on the type of exchange that you're having.
I think you're probably aware that there have been statements from a number of witnesses suggesting that you were not keen on seeing everything written down. Is that not correct?
No, that's absolutely not the case. I would never suggest that. And the reason I can be reasonably confident about that is because it's genuinely not what I think. Infection control, particularly in Glasgow, following the Vale of Leven inquiry, was a very scrutinised service. We were scrutinised externally by Health Protection Scotland, the Healthcare Environment Inspectorate, and by the policy unit of the Scottish Government. And there were a set of standards, the Healthcare Associated Infection Standards produced by Health Improvement Scotland, which indicated very clearly the structures of the meetings that we needed to have, the reporting systems that we needed to have. Far from saying that we shouldn't be writing things down, we were actually judged externally by what we did write down, not what we didn't write down. So we had to raise the appropriate issues. There had to be evidence of escalation through the processes. The meetings were not verbatim, they weren't transcripts, but they were there to evidence the conversations that happened at the meetings and provide a point of reference to anybody looking at it to say, yes, that was raised at that point, and then it was subsequently raised at the other meetings. So I cannot imagine that I would ever tell anybody that these things shouldn't be written down. The two aspects of infection control business are really the routine business, which is covered by the senior management team meeting, which is minuted and document is made of decisions. The other ad hoc business of the infection control team is managing outbreaks, and that is minuted and documented through the IMT process. So each of the processes we undertook as infection control teams had very clear governance routes, had very clear minutes, and the documents were widely available.
So did you not say to Dr. Peters, you're in Glasgow now, we don't write things down because of inquiries and the like?
I have absolutely no recollection of saying that, and I can't even see why in the context that she raised in terms of prophylaxis for meningitis, why that would be in any way appropriate. Prophylaxis for meningitis is one of the most standard infection control procedures that we undertake. It involves giving an antibiotic to people who've been exposed to meningitis bacteria. There's a very clear protocol, a very clear SOP. There would be no reason why in that context I would ever imagine saying we're in Glasgow now, don't write things down. Also, that's not the conversational style I have, so I just don't recognise that comment at all.
I think you do accept, do you not, that there were, before Christine Peters came on board, meetings of infection control doctors prior to the SMT meeting in infection control, which were not minuted and which then became minuted after she complained there was no record.
Yeah, just for clarity, the meetings weren't prior to the SMT, they were between SMTs. So between the SMTs, we had meetings of the infection control doctors and the infection control nurses, which fed into the SMT process. The meetings for the infection control doctors, when we designed the system, were deliberately not minuted because it allowed colleagues, I mean, sometimes being an infection control doctor, as you've probably seen from the documents before, is a pretty lonely place. Sometimes you just need a space to talk to colleagues and put opinions to colleagues. But there was also reference previously, particularly in South Glasgow, to concerns that there was separate decision-making between infection control nurses and infection control doctors. So we were always very clear in the process that the decision-making arena was the SMT, where doctors and nurses and the infection control manager were present, and that the conversations around the infection control doctors and also the infection control nurses meeting were reflected in the SMT minutes but not minuted. Dr. Peters, very shortly after she joined, raised concerns about this. She requested a meeting with myself and Mr. Tom Walsh, the infection control manager. The only concern she raised with me at that point were the minutes around the infection control doctor meeting. And given her kind of real concerns around that and the fact that I didn't see it being a major drawback, although I could see some drawbacks to it, which I'll come back to in a minute, then I agreed that we could minute the infection control doctor meetings, and from that point forward, they were minuting. The system had been in place, I think, since 2009. There'd been 2 or 3 other infection control doctors, microbiologists in the role that Dr. Peters had prior to that. Nobody prior to that had raised any concerns whatsoever about the infection control doctor meetings. And to my mind, subsequent to the minuting, I think it changed slightly the tenor of the meeting, in that it became a, if you like, a subgroup of the SMT. The discussions became more focused on, writing a minute and things like that, rather than the discussions we'd had previously. But as I say, when it was requested by Dr. Peters that we minuted the SMTs, we started minuting.
You said a minute ago, just so I understand what point you're making, that infection control can be a lonely place. What do you mean by that?
You're asked sometimes to make decisions as an infection control doctor that is within your specialty, but you'd like to just discuss with some peers. So it was almost a kind of clinical peer review conversation. I'm thinking about doing this. Does that seem sensible to you? Would that be okay in terms of what would normally happen? That kind of conversation, not decision-making conversations or any attempt to kind of, influence people. It was advisory and conversational, not directive.
And one of the differences, presumably, in the new Queen Elizabeth Hospital, because of its scale, was there's a lot more infection control people involved, nurses and doctors, than there might be in much smaller hospitals.
No, it was the same number of people involved per bed of the hospital. So the main problem with the new Queen Elizabeth was the complexity of the site. Infection control works relatively well when you have a single site with a single group of people managing it. So, for example, in a district general hospital, patients will move between specialties. So 1 minute they can be on a medical ward, 1 minute they can be on a surgical ward. The infection control problems follow them. So one team can then have oversight of the entire building, which kind of facilitates continuity of patient care. One of the problems that we really struggled with in terms of designing the infection control service at the Queen Elizabeth site was the sheer size of the place. There was absolutely no way that one individual infection control doctor could maintain oversight of a hospital of that size with that number of complex specialties. So again, the same people were involved in the Queen Elizabeth as had been involved prior to the Queen Elizabeth, but they were amalgamated into one site.
Now, if we can just go now to your witness statement, we'll use that to walk through the various issues. You pointed out, I think, that you were at York Hill before you moved to the new site.
That's correct, yeah.
And you set out a lot of information, which is very helpful, about the microbiology lab and how that functioned. If we go to page 6, that's, yeah, good. You're making a point here about a shift, I think, away from a specialist pediatric focus into something slightly more general. Is that right?
That's right, yeah. So the laboratory at York Hill was provided services entirely to the hospitals on the York Hill site. So that would have been the Queen Mother's Maternity Hospital and the York Hill Paediatric Hospital. Following the merger, the laboratory became of a much larger size because it had to process samples from not only York Hill, but also from the historical Southern, the historical Victoria Infirmary, and all the GP catchment areas. So the number of samples probably increased tenfold in the laboratory overall. York Hill was a very small specialist laboratory, so that was definitely a change. And there were discussions about whether a paediatric section was desirable within the new laboratory. My view was that it should have been, because it gives you a slightly different focus. A number of infections are different in children. A number of infections have significance in children, bacteria that don't have the same significance in adults. But that view didn't carry the day. The view was that a urine sample from a child can be treated in the same way as a urine sample from an adult. So when we moved to the new South Sector laboratory, the samples from the paediatric hospital were merged into a much larger number of samples.
And you point out later that usually an infection control doctor is a consultant microbiologist, not inevitably, but usually. And I think we've heard that from other witnesses. Is that correct?
That's usually, yes. Simply because the microbiology role and the infection control role cross over to a certain extent. So some, but not all, of the problems in infection control arise from the laboratory. If you're working in the laboratory, you already have knowledge of the laboratory processes, the time it will take to get the samples out. I retained a role as a consultant microbiologist for York Hill throughout my career in NHS GGC. I was the lead infection control doctor and the infection control doctor for the Women's and Children's Services as well, but I maintained the role as the consultant microbiologist. So there is leeway in the guidance as to who can be an infection control doctor. People with relevant experience in public health, infectious disease, physicians, people with that level of experience also undertake ICD roles in some areas, but it's usually the consultant microbiologist.
And the role that you held, which is sometimes described as lead ICD or lead oblique coordinating ICD, had a particular slant. Is that right?
Yes, it's a unique. Well, I don't know if it's unique. It's an unusual appointment, and the lead coordinating bit, which is used interchangeably through a number of, I think, the documents, reflects the fact that it was mainly to recognise the fact that as Glasgow amalgamated into more and more hospitals into a single board, the complexity of the infection control system became more complex. So previously, as I mentioned, you would have one infection control team in each hospital. The consultants treating the patient would work in that hospital, so they were exposed to the infection control advice on that site only. As Glasgow started to amalgamate, then consultants started to move between sites, and they started to raise inconsistencies in infection control advice, not to any major extent, but just, well, we're asked to do this on one site, slightly different on the other site. So there was an awareness that the infection control wasn't consistent across the site. That was the main reason, I think, for the inception of the infection control doctor role, which I was appointed to after, I think it was a number of people applied through a competitive interview process.
But it was a lead role in the sense that you became a member of this infection control senior management team, which was you and the infection control manager and a nursing representative.
Sandra McNamee,
yep.
the assistant director.
And Mr. Walsh.
Yes. And one of the other roles of the lead coordinating infection control doctor was to provide advice and support to the infection control manager. So he would we would meet regularly, I think, from recollection, I think we met every Thursday morning, along with the lead for surveillance, the lead for the data team, and Sandra McNamee, and I think Pamela Ioannidis as nurse consultant, just to basically discuss any things that were going on across Greater Glasgow and Clyde, to monitor progress with the infection control programme, which was our document which provided our kind of like work plan for the year, and also to basically address the nuts and bolts of the kind of management process, the minutes, the information, things like that. So the senior management team was doing all those things.
And can we look at page 9? Yeah. In paragraph 32, you've dealt with the point about the incorporation of paediatric microbiology into a wider adult microbiology. But I just wanted to ask you about the tail piece to paragraph 32, just to see if you can assist us at all, because it's mentioned by at least one other witness that virology and mycology were ultimately sent somewhere else. And you say here it's more difficult to obtain a complete picture of the infectious processes going on, particularly with complex patients. Is that correct?
Yes, that's my opinion on that. We in York Hill for the Challeon unit, we used to have an MDT once a week. I think it was on a Friday.
Now, just so we got make sure we have a note of that. What every week?
It was a clinical multidisciplinary team meeting with the microbiology team, the clinical team, and the nursing team, mainly looking after the haematology patients on the Challeon unit. When we were at York Hill, we had a number of clinical scientists. One was involved in the processing the mycology samples. One was involved in the specialist virology we did. We weren't offering a full repertoire of virology services. We were offering the virology relevant to the very immunocompromised group of transplant patients. So when I attended the multidisciplinary team meeting in Challeon, I was accompanied by the clinical scientist who'd been doing the mycology testing, the clinical scientist who'd been doing the virology testing, and I had oversight of the bacteriology as well as those two things, which actually meant at that meeting we had an awful lot of detail available, not only about tests that had been completed, but because of the nature of microbiology and some virology, there's inevitably a delay between the sample receiving the laboratory and the result being available. So we would call those interim reports. We had ready access to the actual state of the sample at the time we were attending the meeting. As those samples moved off-site, we were more reliant on getting the final results. It became more difficult to collate all the information. We managed to do it. I mean, we weren't concerned that there was any risk to patients, but the process just became more complex than when it was all contained within the one laboratory site.
And just for completeness, mycology is focused on, in layman's terms, fungal.
My apologies, yes. Mycology is based upon the diagnosis of fungal infection. So it involves growing fungi. It involves molecular tests looking for the presence of fungal DNA and other parts of funguses in either blood or sputum or other body fluids. So it's a diagnostic specialty focused primarily on, as you say, fungi.
Thank you. Now, can we move on to page 10? I just want to tease out a little possible contradiction in the way words are used. You explained to us you were a member of the senior management team for infection control, which was you, Mr. Walsh, Sandra McNamee. But in paragraph 37, you describe your role as coordinating, not managerial. It seems a little odd to be sitting on a senior management team but not describing yourself as managerial. Can you help us with that?
Yeah, the contrast is between the infection control service and the infection control doctors who were actually consultant microbiologists. So the sessions for the infection control doctors in the sector teams were people who had a split role as myself between microbiology and infection control, but the balance was slightly different. So whereas I was half microbiology and half infection control, again, the infection control time roughly split between the coordinating role and my individual role as an infection control doctor for the Children's Hospital and subsequently the Women's and Children's Directorate. The microbiologists had a split of usually about 8/10 of their time doing clinical microbiology and 2 sessions of time doing infection control. The consultant microbiologist contracts were held by the Diagnostics Directorate and were managed by the head of microbiology. So I was not involved in the appointment or the selection of any of the ICDs provided to the sectors. I kind of deployed the time and the ICDs that I was given. And again, that system had been in operation since I started in the role in 2009. And there'd never been any significant problems with either obtaining infection control doctor sessions or any tension between the infection control and the microbiology role that I was aware of.
I think that's the point you mentioned, just for completeness, at page 11 of your statement at paragraph 40, that you say the role is unusual in that the lead infection control doctor couldn't choose their own team but could only deploy the individuals made available by another individual who was clinical head of microbiology.
Yes, when I say deploy, I mean that's probably sounds a little bit grandiose. So there would be a conversation with the head of microbiology. They would say, Dr. X wishes to move on from infection control. Most people stayed for 2 or 3 years. Some people stayed for longer. But for example, I think the infection control doctor prior to Dr. Peters taking up their role expressed an interest in gaining more experience in the reference laboratories. So they moved to North Glasgow where the reference laboratories were situated. That means as they'd taken up that additional role with that, they didn't really have time in their job plan to continue with the infection control. So a conversation was held amongst the consultant body, and somebody usually offered to come and be the infection control doctor. That information was given to me by the head of microbiology, the clinical lead for microbiology. And I then, who was coming, and made sure that they fitted into the teams.
Can I ask you an unconnected question? In paragraph 46 on page 12, foot of that paragraph, you talk about ensuring if there's building work, it's done safely and infection control precautions are implemented. Is it correct to say that therefore ICDs were involved in high scribe processes?
Yes. So the document basically outlines work that's done in an existing hospital in terms of modification, and also in the sections I alluded to earlier on outlines the process for a completely new build. I mean, if it'd be useful for me to give you an example, I was involved in a very complex HI scribe process in York Hill. So the bone marrow transplant rooms in the Schiehallion unit at York Hill needed to be refurbished and replaced, which was obviously a relatively high-risk procedure from the infection control point of view, which actually needed very close management, particularly as Dr. Gibson's view was that we needed to continue transplanting throughout that period because of the clinical pressures on the transplant program. So the HI scribe process there involved basically setting out the work that we needed to do, identifying that it was high risk. So in that case, we had to maintain negative pressure throughout the work area to make sure that there was no ingress of any dust or fungal spores into the functioning unit. We involved myself and the infection control team at York Hill at that time, and the ward team were regularly monitoring the security of those arrangements. Again, it was mainly making sure that the seals around the visqueen plastic that was cordoning off the area were remaining sealed, and that the bulge was bulging inwards rather than outwards, so you could actually tell that the processes were in place. The contractors had a much more sophisticated way of monitoring that, but we were basically just walking past the building every couple of hours just to make sure that was all in place, and immediately bringing the attention to the contractors of any potential problems that we saw. That is in complete contrast to the New South Glasgow Hospital build, where it was a building site on the existing Southern General Hospital site. We had no access to the building at all during the development. Even towards the end of the build, we were only allowed into the building as visitors with hard hats to be shown around. It was a building site, not a hospital. So the implementation of the documentation varies dramatically depending on the context to which that documentation is applied.
Your involvement in the work at York Hill that you've just described, when was that?
I think that was back in about 2012 or 13.
2012 or 13.
It's when we were in the old Schiehallion unit on the York Hill side.
Thank you.
We're now going to move to discuss the preoccupation process period, if I can call it that, the period before the hospital was handed over by the contractor to the board, and then in due course patients migrated into the hospital. And we start to see that dealt with in your statement at the foot of page 12. And you say there, the only advice I recall being asked to provide was basic information on hand washing, sinks and fittings in relation to room specifications. And you say we advise this should be to the relevant HTMs. And you say, while there was infection control input, we were not asked to provide any further information than that provided by the ICN as part of the project. So that's very early on, is it, in the process?
That would be very early on. That would be fairly soon after my appointment as lead coordinating ICD. I would think round about 2009, something like that. Very early on anyway. Jackie Stewart would inform us that there'd been queries raised about certain aspects of the specification of taps, things like that. I used to intended to involve Dr. Inkster at that point because I knew she was developing an interest in the built environment. So it was myself, Dr. Inkster, Sandra McNamee and Jackie Stewart had the conversations. Again, we routinely referred them back to the SHTMs because the details of the water and the taps and things are all contained in those documents. We wouldn't, to my recollection, we never recommended anything other than basically build it to the guidance in the SHTMs. The conversations were more, I think, about the availability of the hand hygiene sinks, where they should be in relation to the patient flows. So if you can put, for example, 10 sinks into a room of this size, where you actually put the sinks is material because you want the sinks close enough to be able to easily access hand hygiene, but not close to any critical areas where you might be making up medicines or things like that, just in case of the splash risk. So the conversations were more about the distribution of the fittings in the rooms rather than the actual details of the fittings themselves.
It sounds to me from the process you're describing as if you, and by that I mean you and your colleagues, were reacting to questions rather than directly involving yourself in what was going on. People were coming to you with issues and you were saying, well, if the question is this, the answer is that.
Yes, we were reacting to specific queries, but again, the large amounts of documentation in terms of specifications, how to build a new hospital were there in the background. So it was again operational modifications to those things which we were answering questions on, and that really wouldn't be unexpected because while the design team might have expertise in the plumbing and the ventilation, they wouldn't have had the expertise in how staff on the ward would use those, how they would relate to patient flows to the hospital. So we were more in providing the infection control input relating to those rather than to the detailed specifications themselves.
And what you're saying, as I understand it, is that your position anyway is that much of the material that's needed to carry out the exercise that was being done is set out in HTM and SHTM documents, which you would use as your guide.
Absolutely, but it's also important to reference those SHTM documents to the patients that will be using the hospital.
Because, for instance, SHTM 0301 on ventilation has specific provisions for different cohorts of patients.
Yes, absolutely.
You tell us in paragraph 49 that you had a specific role which was to do with a lab build, not with the general hospital building. And I don't think to ask you about that. And then in paragraph 50, you repeat your point that your recollections that questions related mainly to hand hygiene sinks and fittings, which we agreed would be to relevant national standards. Now, in 51, you say that you asked Teresa Inkster to be the ICD link with Jackie to respond to any questions. Now, I just have to put it to you that Dr. Inkster has no recollection of you appointing her in some way to that role.
I think there may well have been emails at that time to suggest that as she had an interest in the built environment, she would be involved in these discussions, but I haven't had access to any of my emails since I left Glasgow, so I can't confirm.
No, you think you put it in writing. Did you put it into something called a job plan for her?
No, it was just, and it would have been a conversation or an email, probably an email along the lines of, Teresa, being as you're interested in all these things, why don't you be the first point of contact to Jackie? It wasn't a detailed job specification. It was just a suggestion that as she was interested, it might be helpful that she was involved.
Now, at the foot of page 13 of your statement in paragraph 51, you repeat the point about sinks, taps, fittings and positioning of hand hygiene sinks, and you say there were no questions around which ventilation should be used, when and how it should be fitted, or any discussions around the details of ventilation or overall water design. Is that correct?
That's correct, yeah.
I wonder if we could have bundle 14, please, volume 1. Page 21. Now, what we have in this document, Professor Williams, is what appears to be an email from Jackie Stewart to Tom Walsh, Sandra McNamee, yourself, and Pamela Ioannidis, headed ventilation, and dated 2011, so long before the hospital opened, saying, please find attached the ventilation specified so far. I'm meeting with the M&E chaps to go into some more detail. If this is not how you remember the spec, let me know. And then there's a discussion about washing machines, which we needn't trouble you with. Does that not suggest that what you say in your statement is not perhaps complete, because you were involved in discussions about ventilation?
Yeah, so that time I was kind of relying entirely on my memory. This is one of the emails that's been made available to me since. My recollection of that meeting is that the ventilation specification was very high level, that the building will be provided as to HTML 301, and there were no particular concerns raised at that. It was built upon the earlier documentation provided by people in 2009, just basically outlining the hospital as it was and the type of rooms there would be.
Sorry, entirely my fault. You were talking about something happening in 2009. I just didn't catch that.
Sorry, they were the original documentations describing the input that infection control had into the process at that time, with Dr. Redding, Dr. Hood, and Annette Rankin being involved in those advice.
But at least at this time in 2011, it appears you were involved to some extent in ventilation.
Yes, I'd received this email, but again, that was updating me rather than me being involved in the design as such.
Although the email appears to suggest, if this isn't how you remember the spec, let me know, as if you've been involved prior to that.
That's not what I said, and as I say, I wasn't involved in developing any of the specs.
Can we look at 23, just in the same bundle, please? Sorry, yes, there we are. And we see there that there's a list of items: hemato-oncology, a sealed HEPA filtered ward, 10 negative pressure rooms, and so on and so forth. So this is what you were telling us about, that you thought it was pretty high level at that stage.
This is the high level thing, and again, it's listed that it will be compliant with SHTML 301 and SHPN 4.
24, please. Now, this, like all email chains, they're very annoying to put up on the screen because they always start at the bottom. Can we just actually scroll up to 25? I think we'll probably see where this comes from. At the bottom of page 25, we see an email from Jackie Stewart, 23rd August 2012, so a little further on, to you, headed M&E Design for New South Glasgow Hospitals, saying, technical guys wondering if you're available to meet with them. They will outline water systems and ventilation systems in generic format, e.g. bedrooms will have X amount of air changes, treatment rooms will have X amount of air changes, etc. So it sounds as if you're getting into a bit more granular detail by that time, is that right?
Yes, it does from the email. Again, I think from my recollections from that meeting, again, it was very high level, and I'm not sure if there's a subsequent email from me clarifying some points around the conversation.
In fairness, let's see the end of this. So it's responded to instantly by saying Professor Williams out of the office, so we don't need to worry about that one. If we go back to 24, sorry, we see an email from you back saying 17th is good. Useful to have the detail for both adult and pediatric builds around theatre suites, hemo-oncology, and especially bone marrow transplant areas. Proposed airflow, then there's TB isolation rooms. I think if we go back to 25, there are a series of other individual points. So you've gone back, flagging up, again, at least an element of detail about things that you were keen to see. So I take it you followed up and you went to this meeting, did you?
Yes, we went to the meeting. I think myself and Teresa Inkster went to the meeting. I don't recall the meeting discussing anything in terms of high-level ventilation or anything of the like. I think it was, again, just general updates of specifications, and that all these specifications would be built to the relevant HTMs, SHTMs.
Yeah, well, just come back to 24. Just so we look again at the start of your reply to Jackie Stewart. I mean, you're talking about the BMT rooms and airflows. So did you know what you were looking for at that time?
No, we were just looking at general specialised areas of ventilation and saying it'd be good to get the detail on any general specialised areas of ventilation that would have been present in the build.
The reason I'm asking, obviously, Professor Williams, is we know that the BMT rooms, both paediatric and adult, turned out to be problematic in a variety of ways, which we can come to later.
Yeah.
But it looks as if you were at least looking for some information about it at that early stage.
That is the kind of areas that would be of concern to infection control teams. So that would be based upon a kind of list of high-risk areas that you would want to actually discuss in more detail if there are any detailed discussions to be had.
And in general terms, and I may have picked this up incorrectly, so please correct me if I'm wrong. Were you saying that what you were saying is they needed to comply with SHTM 0301?
Yes, that would have been the case, and the relevant health building notes attached to that.
Yeah. Can we look in the same bundle at page 204, please? Now, again, we'll scroll on to 205, just so we see this then. There's a pretty pointed question from Dr. Peters at the top of page 205 saying, how was the design of the new build signed off from an infection control point of view? I.e., who would be a most appropriate person to speak to get an overview of design in regard to ventilation from an infection control point of view? It's a pretty clear question. And the answer we find back on 204, because that was directed to Mr. Walsh. Mr. Walsh, that's your colleague on the SMT, says, hi, Christine, Craig led on most of this with some input from John Hood, which suggests that you had a rather more significant role than you would argue you had.
I had a significant role from August 2014 when we were informed of the decision to move the adult BMT unit and the infectious diseases unit into the hospital. So I can only assume that because Christine was asking about ventilation, that's what Tom was referring to.
It seems a little odd that your colleague on the SMT is saying, oh, Craig's the man for this, with some help from John Hood, if you weren't really very much involved.
Well, I would have been the man for it in terms of the questions around the PPVL rooms and the move of the bone marrow transplant units and the specifications that she was trying to, I think, get at that point. But I wasn't actually the person signing off the input from the hospital. I had no role whatsoever in signing off the building specifications or the infection control specifications for the new hospital.
The combination, perhaps to an outsider, and perhaps you can correct me, reads a little oddly. You're the lead ICD, so that's fine. Mr. Walsh says, Craig led on most of this. And then in the next sentence, he says, design sign-off was by Jackie, who's an ICN. So not a member of the senior management team. But it does it not suggest that you did more on ventilation than perhaps you now recall?
No, I had a lot of involvement in the ventilation from, I think it was August 2014. Prior to that, the only occasions I can recall of having anything to do with ventilation have been demonstrated in these emails.
You can probably understand why people thought you were involved if Tom Walsh says you were involved.
Yeah, I could see that you would take that from it, but as I say.
Can we just look at page 75 in the same bundle, please?
Just so that I've
Sorry.
got not, sorry, just so that I've an accurate note. Have I correctly noted you as you could see why people thought you'd been involved before August 2014? Is that what you said?
Yes, I'd been quite heavily involved since August 2014, so it wouldn't have been, unreasonable for people to think, well, if you were involved from 2014, maybe you were involved earlier on, but it wasn't an accurate representation of the facts.
Oh, can we just look at 75? I'm jumping back, and I apologise that all my questions are not in strict chronological order. But what 75 shows us is an infection control meeting held in the Hillington project office on Monday, 18th May 2009, so pretty early on in the process, with Mr. Walsh and various others. Do you know anything about that?
No, I wasn't at that meeting, and that was before I took up role as lead infection control. I would have been responsible for York Hill at that point.
Okay, we'll go back to your witness statement, please, at page 14. I just want to ask you about something else that you may or may not be able to help us with, but let's see. Can we look at a document, please? Bear with me. Which is in bundle 12, page 813. Now, may say straight away that this is not an email that was sent to you. It was sent to various other people. And it dates from 2016, which is after, well, first, actually after you've left. Yeah. But it's looking back, because by this time it's become apparent that, to put it no higher, there were quite a lot of issues about ventilation in the hospital, the kind of juggernaut that you mentioned. And this is Mr. Seaborn saying, well, there's obviously been an SBAR, and he then says in line 3, no matter what the infection control people say, they were involved in every aspect of the design. Now, from your recollection, is that correct?
I think it depends which period of time he's referring to. I mean, there is some evidence that infection control was kind of heavily involved at the beginning of the process in terms of the kind of drawing up of the original specifications. I think that probably relates back to the document that you just showed at the meeting of the project team in Hillington in May. The continuing and infection control were involved throughout, as I've said, because we had a nurse consultant with the project team who was there to facilitate any discussions or input into infection control. So I would say there's clear involvement of infection control from the beginning of the process, with the original specifications being signed off. I think he mentions.
Yeah, the implication, I think, of this email is that infection control had signed off on all design matters that had an impact on patients, which is what infection control are about, looking after the patients.
But again, I think that refers back to the document you looked at slightly earlier in 2009, where it says this is to sign off infection control agreement on the process. It's the one I think was on the screen prior to this document.
And by this time, I'm jumping ahead a little bit in your witness statement, but you were asked to look at a document which said that instead of the SHTM 0301 air change rate of 6, a different air change rate, which we've had calculated as somewhere between 2.5 to 3, was to be deployed. And this has emerged. As I understand it, you knew nothing about that document. Is that right?
I think
until you saw it in the context of this inquiry.
And I've also seen an email relating to that in the bundle. I can't remember exactly where. It was basically copied into me, but John Hood was primarily involved in responding to that. Is that the document relating to the reduction in air changes in the renal day unit?
Well, yes. I mean, there was an inquiry made about the renal unit, which perhaps had specific concerns. But I think this is concerned with the general question of changing from advice in SHTM 0301 for 6 air changes as a standard every single room to a lower level. So the implication is that infection control were involved in signing off on that change, just to use that phrase generally, i.e. approving it, perhaps risk assessing it in terms of the consequences for patients. Do you know anything about that?
No, I was completely unaware of that derogation until it appeared in the inquiry document.
Sorry, my fault, Mr. Connell. We're talking about the general single rooms at the moment, are we?
Yes, we are. Well, we're talking. I asked the witness, my lord, first of all, about the general statement of involvement of infection control in all design issues, and to what extent that was correct. Because I think you can understand, Professor Williams, that given that you were up until March, April 2016, the lead ICD, somebody might think, well, you should know if there was a significant change of that kind, and you say you didn't.
No, that would be a reasonable assumption, but no, I didn't. So if I had known, I wouldn't have had enough experience to comment on it directly, but I would have certainly sought advice on it.
Yeah, but can I just take that point from you now, because it will probably save us repeating it later on. You're familiar with the requirements of SHTM 0301 and other HTMs, at least in general terms.
Yeah.
But I picked up from your witness statement, and I don't want to put words in your mouth unnecessarily, that you didn't feel you have all of the technical expertise to judge ventilation systems in situ or the like.
Yes, that would be absolutely correct. Yeah.
Thank you. Well, we can leave that document, thank you. We'll go back to your witness statement. It just paints a slightly odd picture if you don't understand the situation, that you're the lead ICD, you don't know about this change. And in your witness statement at paragraph 56 on page 14, you instance an example where you were asked about, well, what do you think we should have about ventilated isolation rooms? And you say, well, we told them what we thought should happen, and it all disappeared, and someone somewhere decided to do something different.
Yes. And at that point, I wasn't the lead ICD. At that point, I was kind of, I think, attending as the infection control doctor for the York Hill.
Just suggests there's a disconnect somewhere between seeking the advice of infection control and actually what happened thereafter.
I absolutely agree. I mean, the decisions that were being made in terms of the specification were being made outside the infection control team. Again, not necessarily inappropriately, because if the guidance is very clear in those areas, then again, I mean, our advice would be follow the guidance. But if there was any dubiety or any concern about the appropriateness or the application of those guidelines, then I would have expected it would have been raised with the infection control team through the nurse consultant with the team. Again, I wouldn't have had any expectation whatsoever that she could have answered it, or necessarily I could have answered it. But if the questions had been raised, we would have sought expert advice in attempting to answer those questions.
I think I was keen not to be pejorative about the role of an infection control nurse, because obviously they're highly experienced individuals and highly capable individuals. But what you're essentially saying is if an issue of, for instance, departure from guidance on ventilation arose, you wouldn't expect the allocated nurse to be able to answer that. And in fact, you might not be able to answer that.
No, I mean, if a question along those lines had been asked, I mean, my hypothesizing it had been asked, my normal route for dealing with it would have been to look at the nature of the question, check the guidance in the SHTMs to see if actually the question was there and it was valid. I would then kind of escalate it through our escalation routes, either to AICC or BICC, and ultimately ending up with probably the involvement of a senior estates person, or if necessary, any people with external expertise.
And if you went to estates, because they're the people who manage buildings and maintain ventilation systems, would you either by yourself or having taken advice elsewhere not need to be satisfied that whatever they said met the infection control requirements that were your concern?
Yes, I would be phrasing the question to estates in terms of the infection control risk, not the engineering specifications, because that's their area of expertise, not mine.
We can perhaps illustrate your point by looking at the top of page 15, where we're coming to the point where you were being asked about isolation rooms and how many and so on. And you say the advice you gave was at a general level. Can you help us understand what advice at the general level was?
Yes, so for example, if you have an infectious diseases unit, you would need the appropriate rooms for isolating infectious patients. I think at the early stage, I think there was a change in guidance nationally at some point from building hospitals as they historically had been built with kind of units of 4 to 6 rooms into entirely single-bedded hospitals. So the conversations earlier on were the number of general single rooms that were needed per ward, for example. So if a patient had Clostridium difficile infection in areas where there's not entirely single room builds, one of the infection control interventions is to manage that patient in a single room. So it's how many side rooms would you need for each routine ward? It was questions of that nature rather than the detailed engineering specifications of them.
So you weren't getting into discussions about things like whether you needed one air handling unit or redundancy, so there was a backup in a specialist ward, that kind of thing?
Not at all, no.
Can I just ask you briefly about what you say in paragraph 58, where this is a set of minutes, and I don't think we need to dig them out. You say you're referring to ventilation in critical care, and you're trying to square the requirement for single rooms with the requirement for observation of patients in with critical care unit within critical care units. Is that right?
Yes.
And you were talking about, do we need to build in glass walls, or what do we need to do?
Yeah.
And you say there's a requirement for the same level of protective isolation to be provided in the ICU, because if you've got a bone marrow transplant patient who needs intensive care, you need protection for them when they're in ICU. Is that right?
Absolutely. Yeah.
Yeah. And so, can you tell us at all, when you were having these discussions, whether you were looking at things like air changes per hour or the pressure differentials?
No, I think that that paragraph is based on my recollections before I had access to the email. So I think the conversations around the intensive care unit may have happened slightly earlier in the process, but in those conversations, it was around clinical observation. So there's a balance to be made between very ill patients on an intensive care unit being invisible, if you like, to the members of staff working in those units, and the need for isolation of the patients. Most routine isolation can be dealt with by bed spacing. So again, there's the theory being that airborne infections drop out of the air within 2 meters if people cough. So as long as the beds are further than that apart, you shouldn't actually have any cross-infection risks, apart from in the unusual circumstances of severely immunocompromised or very infectious patients. So I think this was the critical care unit was a conversation around trying to square those two competing demands of patient observation and the need to go with the guidance of 100% rooms. I think there's a number of emails in the bundle. I can't recollect exactly where that debate was going back and forward between the clinical teams and the infection control team.
can I ask you this then? We know you weren't involved in the contract discussions or checking what arrangements for instance, air change rates had been agreed. When you're coming towards the point where the building is going to be handed over, so we're in 2015, early 2015 for handover and slightly later for patient occupation, was it then part of your role to make sure that the hospital that the patients were coming into had the correct ventilation requirements in place?
Yes, we would have, what we would have planned to do had all the ventilation delivered the specification that we expected. We would have moved the systems that we previously had in the existing hospital. So, for example, in York Hill and in the Beatson, there were well-established air sampling regimens. So we would have actually moved those existing routines into the new hospital.
Professor Williams, can I just ask if we could take that more slowly? You were asked by Mr. Connell, and we're looking at January 2015. Was it part of your role to ensure that the ventilation provision, I'm now beginning to paraphrase his question, ventilation provision in place was appropriate for the patients who would be accommodated? And I think I got, and you said yes.
Sorry, I must have slightly misunderstood.
Might be
that
my
question.
fault.
I apologise. It was my responsibility for the children's area to make sure that the rooms in the children's area were performing appropriately after the handover of the building, but not to ensure that the specification of the ventilation had been met prior to that. We had no idea of the quality of the room build during that point. I mean, it might be helpful to give a little bit of context here. So the phrase was used, handing the keys over, I think by Jennifer Armstrong in one of the, I was surprised by how incomplete the hospital was at that stage. There was an awful lot of work still going on to fit out the hospital, to bring equipment in and things like that. So when you walked in, it didn't look like a finished hospital build. It didn't begin to look like a finished hospital build until probably the end, probably not long before the patients moved in. So it was difficult from an infection control point of view to actually assess the state of the hospital. It wasn't particularly clean at that point. It wasn't, kitted out as a hospital would be. So I don't know if I'm answering the question here.
Well, there might be two separate questions, I suspect, emerging, because we've heard, for instance, from other witnesses that at the date of handing over the keys, work on the children's section of the hospital was still, I think somebody described it, still looked like a building site. Is that your recollection?
I wouldn't go as far as to say it looked like a building site, but it didn't look like a functioning children's hospital.
Well, at that point then, you have the adult hospital, which is more complete. Was it part of your role to check that the necessary ventilation arrangements meeting requirements were in place in the adult hospital before patients started to come in?
No, that would have been the role of the infection control doctors, the infection control teams covering that adult hospital.
Sorry, give me that again. That would have been the role of
the infection control doctor and the infection control teams who were looking after that part of the hospital.
And as lead or coordinating doctor, did you not have oversight of that?
I would have expected them to bring any concerns that they had to me. Again, it wasn't a managerial role. It was not, you will go and do that, you will go and do that. It wasn't directed. They were autonomous professionals in the area that they were in, with basically the leeway to deliver whatever infection control advice they thought was necessary in those areas.
I think you know what I'm getting at, Professor Williams.
Yeah.
We have the handover of the keys. Patients are in the wings, due to come in a matter of months. I'm just keen to understand whether, as lead ICD, you should have been basically making sure everything was ready for these patients in all of the areas of the hospital.
No, it was a huge hospital, and that's why we had different teams working in different parts of the hospital. So I was operationally making sure that the children's area, which was part of my area of responsibility, was to the appropriate specifications. The other teams should have been doing that in their areas.
Right, can I just, sorry, Mr. Connell, just so I capture that. There was an infection control responsibility as at, say, January 2015, to ensure that the respective areas of the hospital, the ventilation provision in the respective areas of the hospital was as provided as, what was at least as provided for by guidance. Have I got that step correct?
The responsibility is kind of part of your clinical duties to actually be aware and visit the areas that you're responsible for. There's no responsibility I'm aware of written down anyway to say you will be responsible for.
Yes, well, maybe I just want to follow your evidence.
Yeah, no, it's fine.
What I'm taking so far, and correct me if I'm wrong, whether it's written down or not, you accept that as of January 2015, there was a responsibility on infection control clinicians to ensure, in respect of their particular areas of the new hospital, that the ventilation requirements were as provided for in guidance. Now, have I got that right or got that wrong?
No, there wasn't a responsibility for people to cross-check the guidance. There was a responsibility for people to visit the clinical areas and look at the fabric of the rooms and make sure that they looked as though they were ready for patients to go into.
Okay, so responsibility to see if it looked as if it was ready. Now, your personal responsibility, again, if I'm following your evidence, was limited to the children's hospital.
The children's hospital, yeah.
Right, so that's the whole of the RHC.
The whole of the RHC.
Right.
And,
sorry, Mr. Cole.
Sorry, and just for completeness, the neonatal intensive care unit, which was part of the retained estate in the Southern General. So I was responsible for the paediatric hospital and the neonatal intensive care unit because the York Hill patients had transferred to join the Southern General's neonatal intensive care unit. That wasn't part of the new build. That was part of the maternity block, which was always on the Southern General.
So we should add the neonatal intensive care.
Yeah, the neonatal unit, yeah.
Sorry, Mr. Cole.
But that's not the what's sometimes called the PICU in the new hospital. This is on another site entirely.
That's a different ward altogether, yeah.
And in terms of what you accepted you were supposed to do, were you looking to find some evidence, for instance, that important things like air change rates and pressure differentials were in place, or was that not part of your role and the role of the other doctors?
No, that wasn't part of the role. Part of the role was basically to walk around and make sure that everything looked as it should, that it was clean, that the equipment was stored correctly. Basically, the number of things that you would do routinely as part of your infection control duties around the hospital.
Yeah, we can understand this in part, Professor Williams, from the discussion we had earlier about validation, because validation of a ventilation system has been described, broadly speaking, as the client getting someone to check that it's doing what it should do so that they can safely say, fine, we'll take it over.
Yes, that's exactly.
And you're happy with that description?
Yeah.
So before you put patients into any particular environment, the ventilation should have been validated.
It should, as part of the HTML 301. And I think, from recollection, the HTML 301 is entitled Building and Validation of. So it's part of the same process.
So was that the point at which you, in relation to the pediatric areas and other ICDs in relation to the general areas, should have first been saying, where's the validation?
That was the context that we were asking for the validation in, yes.
And as I understand it, the significance is that the client doesn't take the area unless somebody says, yes, we've checked it against the appropriate standards, and you, the client, can happily take it over. So did you not really have to say no patients in till validation is established?
Again, we were continually assured that the validation had happened by the routes I've said earlier, people attending committee meetings, emails and conversations. We had no reason to expect that the validation wouldn't have happened. It's an integral part of the HTML 301 process. So we were never led at any point to believe there was any concerns or any problems with the validation. I mean, with hindsight, sorry, Mark.
No, sorry. Please carry on.
From my point of view, the validation means that this has been looked at by experts, external experts, and is good to go.
Right.
So it's a tick in a box. Yeah, somebody says, yes, here's a report, but essentially, to use your phrase, it's good to go. And I'm just wondering how as an infection control operation, you square the need for validation, which you understand, and letting patients in without having any evidence of it.
Because the SHFN process around the handover of and the HI scribe process is very clearly documented. And one of the major questions in the scribe process is, does the ventilation comply with HTML 301? There's a number of supplementary questions beneath that in the scribe checklist, and the responsibility in the SHFN is very clear in terms of the checklist and the process of HI scribe, which should have been done by the project manager. We were being told by the project team the validation is there. We were not being informed of any problems with the validation. I think it's absolutely reasonable to say, how far should we have pursued that? We took it to the Board Infection Control Committee meeting. We requested information on a number of occasions. I think that's a fair question.
Yeah, no, I'm trying to follow it through because I follow the logic of somebody assuring, oh, everything's all right, fine. But the validation has to be done. I mean, as I have heard other evidence, validation is only done once. It's done when the ventilation system is put in place. Then there can be later verifications or a new validation if more works are done. But essentially, absent those factors, it's done once. So if somebody says it's done, then I suppose I'm just struggling to understand why it's difficult to get hold of the paperwork for it.
I don't know.
Can I just take a step back to see that I am following your evidence, which I think is quite clear. The hospital has been brought to the stage where the contractor says it's complete, and at that point, the contractor will, or whoever is the supervising officer will provide, in terms of the contract, a certificate of practical completion. And that's one sort of certification. But you are reminding us that SHTM 0301, in the version that was then applicable, requires, as you've put it, validation from an independent expert quite over and above what the contract provides. Now, that's what I understand you to have said.
Yes, I'm not sure whether the SHT...
And that is additional to anything that is required as part of HI scribe.
Yes, the SHTM, I think, I mean, I've got the details in notes, so if it help, I can provide the details later on. Outlines commissioning and validation as two separate processes.
Yes.
I don't think the SHTM specifies as such it needs to be an independent contractor, but I think the SHTM does point out that because of the expertise required to undertake this validation, it's unlikely that any one individual would probably would have the abilities to take those. So.
Right.
So that usually that you would then anticipate that the validation would be done by an expert brought in by the board or whoever to do that process.
Brought in by the person responsible for that process, yes. Thank you.
Well, I'm conscious of time and I'm about to move on.
And maybe just to finally wrap up, we have been using the expression validation. And do I take it, your understanding of validation is the validation requirement arising out of SHTM 0301?
Yes.
Right.
If
well,
may I refer to my notes? I can actually find the
A,
definition if that's helpful.
I mean, you know, if you wish, by all means, yeah.
So, SHTM 0301 validation, a process of proving that the system is fit for purpose and achieves the operating performance originally specified. It will normally be a condition of contract that, in inverted commas, the system will be acceptable to the client if at the time of validation it is considered fit for purpose and will only require routine maintenance in order to remain so for its projected life.
And I guess that you're reading from chapter 8 of SH.
The validation of specialised ventilation systems begins on page 114 of the SHTM.
Which is in chapter 8, I think.
I don't know, I'm sorry.
Right.
Well,
we usually take a coffee break at this point, and can I ask you to be back at 5 to 12? Mr. Connell.
Thank you, my lord. I'm going to move on to a different section just in a moment of your witness statement, just to show us where we've got to. But I wonder if I could ask you, first of all, to look at one document, which is in bundle 12, at page 179. This again, I'm just trying to get a picture. Can we look at the very bottom of the page there? And I'll explain why just in a second. This is from somebody called David Bell to a range of people, including Christine Peters, copy to Ian Powery and various others. So if we then see he's responding to these people, we go on to page 180. And there's a long discussion, and I'm not going to trouble you with all of it, but Mr. Bell is saying in the first numbered paragraph near the top of that page, the ventilation specs have been forwarded to you now by Ann Hartness, and these were previously okayed by Craig Williams from IC. If the system is currently not working, that's something we're not aware of. At least the wording of that email suggests that first of all, you've done something with ventilation specifications, so something more than just general stuff. And secondly, you've okayed them. Can you explain what your role here was?
Yes, this relates to the when I got involved in the ventilation following the change in specification for the patients moving into the adult tower bone marrow transplant, adult bone marrow transplant unit and ID unit from, I think we were informed in August 2014. That created problems in terms of, as I mentioned before, the SHTM 0301 being seen in the context of the guidance. So the SHTM 0301 guidance states that, I thought the HBN, I can't remember the guidance, but it basically specifically states that this guidance does not describe how you would build for an infectious diseases unit or a bone marrow transplant unit. The process that's being described here is my involvement subsequent to that email in trying to assess the suitability of the rooms that had been provided as of 2014 for the change in patient use, which was going to happen when the patients moved in the hospital. And there's a whole pile of email correspondence with myself, David Loudon, Corrie and Brown, and other specialist engineers trying to compare the guidance has been implemented in the New South Glasgow Hospital with the guidance for the isolation of patients with multi-drug resistant TB, which is a kind of an exemplar of an infection spread through the respiratory route, which concluded in the professional opinion of the engineers being that these rooms could be used under the MDR-TB guidance, which we accepted in the absence of any better guidance, and that was the okaying. The okaying process was done through the Board Infection Control Committee. There was input from the Board Infection Control Committee there. So I think that'll be in the minutes later on. So
if anyone was to take from this email that you, using your expertise, had looked at specifications and okayed them, that's not the process that this is talking about.
I raised the concern in terms of the mismatch between the existing guidance and the patient change, and got an opinion from the engineers who'd had designed, and I don't know, but they were involved in the design of the New South Glasgow Hospital, and it was that advice that was communicated back to the clinical teams, not my personal opinion. Interestingly, I don't know if it's any relevance at this point. The debate around these PPVL rooms has kind of gone on back and forth for a while. The 2024 update of HBN 0401 Supplement 1 now allows for the use of the PPVL rooms in those patient populations. So immunocompromised patients. That's English guidance. I don't know whether it's been translated into Scottish, which to an extent vindicates the professional view taken by the engineers that the rooms compared to the TB guidance were appropriate to use in this circumstance.
But at the stage of this email, there seem to be quite a lot of questions still flying around, because if we look down the page, given you've mentioned MERS, sorry, it was still on page 180. you see near the end of the long email, MERS is a different issue, where the writer is pointing out that ventilation is critical and raising various questions about filters and so on and so forth.
Yep. Again, MERS is a more recently emergent infection, but is spread in the same way as multi-drug resistant TB, so through the air. So if a room is specified as appropriate for multi-drug resistant TB, which is kind of exemplar of infection spread by respiratory route, then in the absence of any guidance specific to MERS, you can actually use the TB guidance and it will work for all respiratory infections.
Right, can we go back to your witness statement so we can see where we are? Page 17, please. And I think what you're telling us there, it includes the statement which we've unfortunately come across already about the possibility of an immunocompromised individual who is also infectious for one reason or another. And we had some evidence about that the other day. And then in 65, you're picking up the fact that originally one of the ideas was you could have rooms that could be negative pressure or positive pressure. And then it was decided this was not a good idea because the wrong patient in at the wrong time or with the wrong switch pushed and you had a problem.
Absolutely. Yeah.
And therefore these were no longer in use. So if we go on to page...
Sorry, could I just add a point to that?
Yes, please.
There's the possibility of a patient, as you've outlined, with both an infection and immunocompromised at the same time. But we're not talking about the context of these in bone marrow transplant use. We're talking about the context in intensive care units or renal dialysis units. So if a patient needs to be cared for,
the context is
of basically patients who need treatment in specialist units that you referred to earlier, either for ventilation in intensive care or renal dialysis in the renal unit. It's not possible to provide these facilities in every unit in the hospital, so patients tend to move to those units for that type of treatment. The additional advantage of these rooms looking hospital-wide is that they can be used for either infection or immunocompromised or a combination of the two. So you don't need to set up two different types of isolation room in the intensive care unit areas or in the renal areas. They can be used one day with appropriate cleaning and disinfection for an immunocompromised patient, the next day for an ID patient. So it gives you much more flexibility in the use of the rooms. The guidance also doesn't really recommend and probably advises against mixing positive and negative pressure rooms in the same suite because of the complexity of the airflows. So if you only have one area in an intensive care unit to house patients from either an infectious diseases unit or a bone marrow transplant unit, these rooms are a solution to that. So it's not necessarily they will only be used for patients with both infection and immunocompromised at the same time. They can be used on one day for an immunocompromised patient, and in the same intensive care unit, they can be used for an infectious patient subsequently.
right. Thank you.
And am I right in thinking that you've highlighted a recent change in the guidance, but at the time these rooms were not recommended for bone marrow transplant patients or highly infectious patients?
Again, the guidance said that it didn't describe guidance for that. It didn't say these rooms should not be used for. If the guidance had been clear and said these rooms should not have been used for, that would have been the end of the conversation, saying, well, actually, these rooms can't be used for this purpose. What we were left with is if you like, a hiatus in the guidance between the previous HBN, which didn't describe the guidance for this type of room, and the current HBN, which does. And we were trying to interpret the provision of the rooms to the nearest comparable guidance that we could find.
We can probably pick that up on the next page of your statement, which is probably what I was rather badly attempting to quote from, paragraph 68, where you say the technical guidance SHTMO 301 stated in Appendix 2 that the lobbied side rooms are not suitable for bone marrow transplant patients of a use on infectious diseases units. And then your point is, but they don't go on to say what is.
Yes, that's absolutely right.
At that time, the advice was no, but not what else.
The advice I don't think was even no. I think the advice was the guidance does not describe. So it's not a prohibition. In my reading of it, I mean, I'm sure there could be a debate around that, but that it wasn't a prohibition, it was an absence of a recommendation.
Right. Well, that may answer a question that occurred to me when I was reading your statement, because I couldn't find in Appendix 2 a statement that it was not suitable. But the point you're, or at least Appendix 2 of SHTM 0301, but you're not actually saying that there's a statement that it's not suitable, but it's an absence
Of guidance for those patient populations. So that I think, I can't remember the exact wording, but I'm pretty clear this guidance does not describe facilities required for severely immunocompromised or infectious disease unit patients. But I would need to go back to the guidance and check that. Apologies for the lack of clarity. I'm just obviously paraphrasing. So
Just looking at what else you say in that paragraph, you say you don't know why the particular lobbied side rooms were chosen. Then you say, well, I'm not saying they're unsafe because there are similar rooms at Great Ormond Street and in Leeds, and these are hospitals that are selected for mention because they have BMT units. Is that right?
My knowledge of the situations in Great Ormond Street and in Leeds and possibly Birmingham dates back to a conversation that Professor Gibson started with me. I think there should be emails to this effect. She'd been informed by the project team that these rooms were to be used in the Schhalling unit. She had no experience of them. She emailed me to ask my view about them. At that time, I was a member of the paediatric microbiology group, which was microbiologists from most of the large teaching hospitals in the UK. I contacted a number of colleagues to get their views on the utility of these rooms, and it was very clear that they were actually successfully in use at the hospitals mentioned. They have bone marrow transplant units, and Great Ormond Street deals with very complex patients. The conversations that I had with the consultant microbiologist there were, the rooms have been providing us with adequate air quality and we've had no clinical adverse outcomes with them, but he did highlight the importance of continuing maintenance for these rooms because the integrity of the room depends entirely on the standard of the ceiling of the rooms, ceiling as in seal, not ceiling.
Yeah.
And he made the point that if these rooms are in use, there needs to be very rigorous schedules for what we call planned preventive maintenance, the PPM that's referred to. But he had no concerns about the safety of the rooms in use at Great Ormond Street. And having heard other evidence that's been presented to the inquiry, in particular, Pamela Joneid has referred to a delegation that went down to Great Ormond Street. That certainly, in my recollection, didn't happen after we uncovered the problem. So I'm assuming that that was part of the specification process where a team visited Great Ormond Street and developed the ideas about these rooms. At that time, I wasn't aware about the visit to Great Ormond Street, so I really wasn't clear why the design team had gone down that route.
When you mention in the foot of paragraph 68, that these work effectively as long as they're built and validated to the correct standards, do you know what these standards are?
The standards are outlined in the document, either the HBN or the HTM. There's detailed validation standards. Pardon me. Again, the rooms, the argument about these rooms is in the context of the patient population. In the context of the design of the hospital before the decision was made to move the adult bone marrow transplant units and the ID unit onto that, these rooms were the ones that would have been specified in that guidance. So they're a well-recognised design used widely across the UK, and there's clear standards for validation and subsequent maintenance for the rooms.
There was always going to be a BMT unit in the new hospital, but it was a paediatric one.
Yes.
So that decision dates way back before the hospital was occupied. Is that right?
And again, the argument about pardon me, the concurrent cases of immunocompromised and infectious cases is much more relevant to a paediatric bone marrow transplant unit because children post bone marrow transplant often have viral infections. And in that case, they need to be both protected from the ingress of any airborne spores, but also there needs to be mechanisms in place to protect the rest of the unit from the infections. The patients having a very low level of immune function tend to shed virus at a higher rate than patients without, because you don't have the immune system to damp the infection down. So they are actually probably even more infectious than children without that level of immunocompromise.
Just a small issue in passing. You deal with air sampling, where you say there was a regular process of sampling in the Schiehallion unit when it was at York Hill. We had a little bit of evidence about this earlier in the inquiry. Would you think that's a useful thing to do?
Yes, I think it's a very useful thing to do. I think the problem, though, with it is there's no nationally agreed standards for the amount of. There are international recommendations, but nothing prevalent in the UK. So it's important that you establish a kind of longitudinal picture of the behaviour of the unit in your hospital. And if there's any deviation from that baseline, that suggests there's a problem. So yeah, we were very convinced at York Hill that the air sampling was useful.
Now, can we move on, please, to start to look at least at the BMT units, both in the adult and in the children's hospital. We come to page 20 of your statement. And you see that the first question there is, did you provide input for the clinical output specification? Now that's for the adult BMT unit.
Yes.
And you say you didn't. And you think that was John Hood, if that was involved. You've had a chance to look at the specification that was provided, is that correct?
Yes, it was. It formed the basis of the conversations we were having after the problems were identified in the adult bone marrow transplant unit, where the first conversation with the contractor was, had they been supplied with remotely an appropriate specification for the build of that. The piece in the specification which actually I think makes it suitable is the section that says these should be provided to the same standard as the Beatson Oncology Centre in the west of Scotland, which was a well-established and well-functioning unit. So it should have been clear at that point in that specification that that would be the benchmark that would have been acceptable for that unit.
Again, trying to look back and find out why things happened the way that they did. Am I right in thinking that the clinical output specification, which you think is adequate, doesn't specifically mention an air change rate?
It doesn't, no.
Because they, as you probably know, when things had to be done to try and fix the adult BMT unit, one of the issues that was then encountered was that the air handling kit that was in place, for reasons that we've touched on elsewhere, was not capable of producing, for instance, 10 air changes an hour. And I suppose that the question is it really a suitable guidance to what is to be built if it doesn't tell the contractor what air changes an hour are to be provided?
Yeah, I don't think it was meant as a specification. My understanding of the process, and as I say, I wasn't involved at that point, but my understanding is that the clinical teams provide a broad specification for how they see that unit being built. So we are telling you that this is a unit which will house severely immunocompromised people, will require specialist ventilation. I think all those things from recollection are in that document, with a final proviso that it should be to a similar standard. This was not a specification document for the bone marrow transplant unit. The clinical output specifications are translated into building plans and designs at some point in the process by, I would imagine, specialist engineers with expertise in understanding the clinical output specification and what implications that has to that build. This was in no way ever meant to be a detailed specification or checklist as to how to build a bone marrow transplant unit. That was my understanding of it as I read it at the time in 2015. I would imagine there was a number of clinical output specification documents for various areas of the hospital, specifying the type of patients and the use to which those units would be put.
The difference with the BMT unit was that the BMT decision, or the decision to move the Beatson BMT unit into the new hospital, was a decision taken during the course of the construction of the new hospital. So whatever the arrangement was for clinical output specifications for matters originally, this was coming in the midst of building. This is why I was asking about air changes, because for instance, we've heard about other things like redundancy of air handling units, whether you should have a backup one and so on, but just stick to air changes for the moment. If nobody says this will need to provide 10, or I think the Beatson was probably 10 to 12, the information I have, no one says that. Is that not a big gap, which you then have to rely on somebody else to work out?
I don't know what brief was given in 2009 for the production of that document, so I don't think I can usefully comment on that, but my understanding of it is that this is not a design specification that would have needed to be translated into a practical solution, if you like, to the set of problems raised by the clinical team to solve the accommodation for that group of patients.
You understand why I'm asking the question, because on the face of it, if you knew as a contractor what air handling units you were putting in, as the hospital was being built, you might have been able to come back and say, sorry, no can do. We can't do 10 or 12 or whatever the figure is you want.
But there is presumably a whole stage between this outline specification and the detailed plans provided to the builder. So at some point, somebody is actually drawing up a set of documents that the contractors can build to. And that is the process, I think, where the outline specification should have been translated, if you like, into air changes to make sure that that unit met whatever guidance was available at the time. And failing that, met the specification which was provided for the Beats Oncology unit.
Yeah. Well, I think the information we have suggests that if you went to the Beatson and did some air change measures in the bone marrow transplant unit, you'd have come up with air changes of, whether it was 10 or 12, doesn't matter for present purposes. And we're just trying to understand how you can get to this remarkable position whereby bone marrow transplant patients move in, take a pretty quick look with assistance from various people, and then have to move right back out again, which must have been highly undesirable.
Absolutely. I mean, I think the question should probably be posed to the project team as to what their process was for translating the clinical output specification into a detailed design specification for the contractors. There was an email, which may or may not be relevant to this, which kicked off my involvement with the ventilation in the New South Glasgow Hospital Tower, where we were informed by the project team that the move was going to be made. And from recollection, I think the email says that the decision was taken by Jane Grant in 2013 and appropriate amendments were made to the plan at that point.
Well, maybe you don't know, but just tell me one way or the other. The indications we've had is that the people in the Beatson BMT unit were expecting to get an equivalent to what they had,
Yes.
I mean, subject to room layout and so on, when they moved.
Absolutely, and I think that was the expectation of all of the clinical teams, including the infection control team, that it was a brand new hospital, that we would be moving to a place that was better than the ones we'd left.
Yes, as good as or better is what you would expect.
That would be I mean, it seems pointless to spend £875 million or whatever on a new hospital and it not be better than the one that you've vacated.
Thank you. When you're dealing with this in your statement, in paragraph 79, we've kind of gone back a little bit to page 21, we've gone back a little bit to the general question about input from infection disease doctors into the overall process, which we dealt with earlier. Can I just ask you, while we're here, to look at bundle 14, volume 1, page 25, please? That's sort of taking us back to a series of emails about ventilation. If we just look at 26, no, we can forget 26, 27. This seems to be for you in 2012 sending information about guidance on water, is that right?
Yes, that's, I think, subsequent to the meeting that you mentioned earlier on the, I think it was the 17th, so it was the day before. There was a question of what was discussed at the meeting. Those are not specifications for a water system, they're specifications for the quality of the water that should be provided by the water system. And I can only presume from the timing of the emails that the main matter subject to discussion at the meeting the day before would have been around the renal unit and the water quality, which was hence my response in those very specific terms.
And a renal unit has special requirements for water because of the nature of dialysis, is that correct?
Absolutely.
And we just look at 28, so we finish at 29, it's finished, no, forget that as well, 30. Now here we seem to be dealing with isolation rooms. Here's an email from Jackie Stewart, Sandra McNamee, isolation rooms. I'm a bit confused as this design was accepted and Craig has been asked on numerous occasions to check issues that crop up. Craig, specifically asked Craig what he wanted to go into detail as well as the overall approach to ventilation and water supply. I'll double check the ventilation in lobbies. So is this not further indication that you have been engaging in various exchanges about ventilation during the process of getting the hospital up and running?
As I said, these are the only two occasions with these emails that I can remember or be reminded of that I engaged with the ventilation. And again, it was specific issues. There was no discussions about the specification of the rooms or how they would be built, air changes, anything like that.
Okay. Well, let's go back to your witness statement then at paragraph 80 on page 21. And I suppose that the first question I have to ask you in relation to your first sentence is why. You're the lead infection control doctor. You'd no input into designs or specifications for the BMT in the children's wing?
No. The first I was made aware of the specialist ventilation in that area was when Dr. Gibson contacted me, as I described earlier, to say that she'd been made aware that these rooms were being provided for the unit. What were my views and could I find any information about them? And that's when I contacted my colleagues, as I mentioned earlier, at Great Ormond Street in Leeds to get further details on them.
So with benefit of hindsight, it'd be better if you knew about this beforehand, had a discussion rather than finding out afterwards and having to go and find out how they work.
It would have been better to have the conversation beforehand. But again, I would have referred back to the guidance, but given the dubiety in the guidance, I would have probably followed the same process that I did for the adult ID unit, where I sought specialist advice about these things, which is what I did at that time.
Yeah. What we find in paragraph 81 is actually some of the narrative that you gave us in answer to an earlier question about having conversations with other hospitals about this. But I suppose that the question I have for you is this. You're trying to find out if they work. And in a general sense, the answer is yes, they do work. Is that correct?
Yes, that's right.
But in the middle of paragraph 81, you say that the advice you got was that they were working effectively, but, there's a but, they required a high level of ongoing monitoring and maintenance because they tended to leak. So there's a qualification to the approval of these items. Is that correct?
That's in subsequent use. So the rooms were built initially to the guidance, but I can't recall the time period. I think John said something like about 18 months or 2 years after the build, they started to detect problems with the routine air sampling being slightly above the normal measures. And when they started to look in, then they found the cause was the small leaks in the ceiling in the seams. So it's a qualification in terms of long-term use and maintenance rather than suitability in the first instance.
Well, that's what I was going to ask you, because if you're trying to reassure a clinician as to the suitability of the item, do you not need to add to your assurance the qualification that, you know, as you put it here, a high level of ongoing monitoring and maintenance is required, or further in your statement, a lot of particle counting and pressure testing when you began to use the room? And did you pass these qualifications on to Dr. Gibson?
As I say, I can't recall what the email reply to Dr. Gibson was, but I may have done, I may not have done, but I would have ensured that the maintenance and the monitoring of the rooms would have been to an appropriate standard to preempt any problems when they were in use in the Schalian unit.
So what did you do about it? Because your statement, and I accept this is a recollection, your statement simply says, you emailed Brenda Gibson to advise her the rooms were being used and with appropriate monitoring and maintenance were effective, which at least in these terms doesn't alert her to the fact that you need a high level of maintenance and lots of pressure checks and so on. So what did you do to reflect the qualifications that had been given to you to the approval by your colleagues?
I would have, at a later stage when the rooms were handed over, ensured that as part of the HI scribe bundle, one of the part 4s is that the estates team meet and describe maintenance. I would have input into the maintenance at that point, but that became irrelevant because the rooms were never actually built to a specification that delivered the outcome.
I'm just trying to follow the logic of this, because this is the pediatric BMT unit, which is a unit that's always going to be there.
Yeah.
So did you make special arrangements for monitoring and maintenance?
There were no arrangements for monitoring and maintenance at that point, because we were talking then about the specification. The unit didn't exist at that point. So this was it was in the planning stage when there was enough information made available to say what the type of the rooms were, but the rooms were not handed over to us. I would have, as I say, made sure at the time of when we took up the responsibility for the air sampling that these rooms were air sampled probably more frequently than we did at York Hill, and ensured that the appropriate level of maintenance was built into the estate's documents PPM. But at that stage, we weren't talking about real rooms, we were talking about rooms on a design, and were there any major problems with that design rather than the reality of the rooms.
Now, you said in answer to an earlier question, and I just want to make sure I've got it correctly, that in fact, as it turned out, they weren't built to that design anyway.
They weren't built to that. They didn't deliver the specification that design should have delivered. I couldn't say for certain whether they were built to that specification.
Right, but whatever the design was that you'd gone to inquire about, that wasn't what was built.
I think there is some questions around that in some of the emails that I've seen. I think there are some emails from David Loud that I've seen in the inquiry bundles where Curry and Brown say that the rooms were built to those designs. The design of these rooms wasn't in debate, so the PPVL rooms were well described in the documentation for use in hospitals. They weren't designed, they weren't specified for use in this patient population, so the design was clearly outlined in the SHTMs. I can't remember the details, but I'm sure there are statements in the emails that these were built to that design.
Well, yeah, I think you're right. I think there are certainly claims that they were built to that design, but I thought you said that they were not built.
No, I'm sorry, I must have been slightly inaccurate. What I meant is that the rooms didn't deliver the outcomes that we would have expected to rooms of that design to be built to. So we would have expected rooms of that design to provide clean HEPA-filtered air to the patients in the room. That clean HEPA-filtered air wasn't being provided. when we got to the reality of looking at these rooms.
Right.
So it's a question of how the design was implemented, I think, rather than the actual design. But again, I'm not an expert in design, so.
Yeah. Very well. Let's move forward. In a following section, you're dealing with the fact that there were 2 units moved into the new hospital that weren't originally scheduled to be there. One is the BMT unit from the Beatson that we've touched on, and the other was, we've been talking about the Brownlie infectious diseases unit. And you've been asked in your witness statement about any concerns. And I think you say on page 23 at the top that the decisions weren't yours, but you were asked to provide views on that as a team. Is that right?
Yes, that's right.
And the one you were more bothered about was the ID unit, because you were going, to paraphrase what you've said here, moving from a standalone unit with its own entrances and so on and so forth to, as you describe it, putting an infectious diseases unit in the centre of a tower block in a large hospital,
Yeah.
which raises presumably entrance and exit routes as questions, including
Yes,
refuse. Is that right?
yes, that's the concern. So the patient, once the patient's in the isolation room, then that's a controlled environment, so you can prevent the spread of infection. But the patient has to get to that room. Patients appear in ED or in a variety of ways. They don't basically materialise in the controlled room environment. But there's also then the problem of highly infectious waste, which there is a number of well-documented procedures for dealing with, but it increases the risk by having to move that infectious waste from the patient's room to a disposal point. So we were initially concerned about those, plus the total number of the lobbied side rooms that we'd mentioned earlier on. So increasing the ID unit may potentially increase the number of patients needing isolation. Therefore, were there sufficient rooms provided for that purpose? They were our concerns at that point. I don't know whether it's appropriate that we go into how we address the location of the bomb the ID unit concerns now, whether you want to.
Well, I was going to ask you about the ventilation requirements. In 88, you're talking about you're getting difficulties in getting the patient into and out of the unit and providing appropriate ventilation. So what standards were you looking to provide for the infectious diseases patients?
Yes. So this comes back to the wording in the building note that infectious diseases units were not described in this specification. So we'd been provided with rooms that were specified to the original SHTM or 301, but the guidance had said that these rooms were not, the guidance didn't describe these. So the question at hand was, can these rooms be used for the isolation of patients with transmissible respiratory infections? And the best guidance available around that was relating to multi-drug resistant TB. So we weren't talking about only patients with multi-drug resistant TB. We were using the MDR-TB as an exemplar infection to say that if the rooms are safe to prevent this very serious respiratory infection spreading, they'll also be safe for other respiratory infections. And that was the question that we posed to the design team, as to was the specification that they delivered to the new hospital equivalent in terms of airflows and protection to the infectious diseases, the MDR-TB guidance, which was published by the Department of Health sometime previously.
And what was the answer?
Yes.
Because the other way of doing it, presumably, would be to find out what provision was made at the Brownlie unit and to duplicate that in the new hospital.
Yes, it would have been. But by this stage, the new hospital was built. So if there'd been any dubiety about the safety of these rooms raised by the engineers, the infection control team would have fed back and said, it's not suitable to move these patients. The question we were trying to answer is it safe to move the patients into the hospital as it stands?
I think there's a question as to whether negative pressure rooms, which had been provided in the Brownlie, were provided in the new hospital, and the answer was no.
because, as I say, the specification didn't originally ask for an infectious diseases unit. We were trying to ascertain whether the rooms that were present in the new hospital were suitable, if you like, for the infectious diseases patients. Again, to paraphrase, the opinion of the expert engineers was they provide the protection. And as I've said, the rooms are now specified in the new HBN as suitable for that.
And I think you make the point in 89 that you had to think not only about the unit itself, wherever it was going to be based, but also about the possibility of intensive care protection. Is that right?
Yes, and that's for the same reasons as discussed previously, that patients don't entirely spend their stay in the hospital necessarily on the unit that they're admitted to. So, for example, a patient with MERS, a respiratory infection, may require ventilation. That ventilation can't be done on the infectious diseases unit because of a lack of anaesthetic expertise, a lack of facilities. So at that point, the patient would need to be transferred for intensive care to that unit. So there need to be rooms available in that area that meet the protective specifications for those patients. And I think that was one of the major drivers of the infectious disease physicians, although you'd need to cross-check with them. They actually wanted to have proximity to both the diagnostic facilities and the intensive care facilities that were present on the new site, which weren't present to that extent on the Got Naval site. So that was a major clinical driver for them in wanting to move to the hospital.
Now, we're coming back to validation again in the way that sometimes happens. We've touched on a lot of this earlier. I suppose I just really have one question I want to come back on, and if I've asked you about it already, then please bear with me. I suppose I'm just trying to get to the point of saying, well, you say here the infection control senior management team repeatedly requested information from the project team about the validation reports and the specialist units and operating theatres. We're continually assured all areas are being built and validated to the relevant standards, but no documentation was provided. Now, you then say we were never told it hadn't been performed. Well, first of all, do you remember who actually provided these assurances?
Again, there is an email in the bundle, I think, from one of the project team to, I think it was Jackie Stewart, the infection control nurse who was leading the project, saying that all the hospital had been built and was compliant with the appropriate legislation.
Because on the information the inquiry has at the moment, no validation was done.
Well, I have to say I'm not surprised about that, having seen the rooms in the state that they were in when we took them. There's also immediately after the project, the problems were discovered at the adult bone marrow transplant unit. There was an email to myself and a number of others from Ian Powery, who was one of the estates officers on the Southern General site, saying that Brookfield had not performed, I think it was the HEPA filter particle testing and pressure differential testing to those rooms, which again would have been an integral part of the validation. So, I mean, it would, in my opinion, that would suggest that the validation was never done.
Yeah. I mean, you use the expression, we were continually assured. Now that suggests to me, I may be wrong about this, that you were making repeated requests, and you say the request would be directed to Jackie Stewart. Is that how I am to understand this paragraph?
I think repeated is over the period of time from when we started coming.
Sorry.
So the repeatedly was over a period of time. So we were repeatedly over several months through various different fora asking for information on this,
Right.
which had culminated with us requesting a member of the project team to attend one of the acute infection control committee meetings and specifically answer whether the validation and things were proceeding. I can't remember the exact date of that meeting, but there should be minutes available of that meeting.
Right. So I'm right to interpret that as a reference to repeated requests.
Yes.
So the requests were not being met, and you were not surprised, looking at the hospital, that there had been no validation.
When we got to the point where we started to look at the clinical units in detail,
So
I mean,
you'd started to,
if I use my own example, because that's probably the best. So when the Schiehallion unit was in a state that it started to look like a proper hospital, which was towards the end of May 2015, Claire Mitchell and I went to walk around the unit to make sure that everything was in place and everything was okay. I was surprised at that point to see a workman in one of the isolation rooms still fixing things to the walls, because the whole premise of those positive pressure ventilated lobbies is that the patient room needs to be sealed so to direct the airflow appropriately from the HEPA filter to the patient. Anything that potentially affects the integrity of that wall would basically make the rooms functionally less useful. So when I walked onto the unit, the first thing that I noticed in the anteroom, there's vents similar to the ones in the ceiling here. You could actually see the silver ducting on the other side of the vent, whereas the flexible tubing on the other side of the vent linked to the air system. There should have been a HEPA filter in place there, because that's where the air should be HEPA filtered. And then when I went further on into the room, it was clear that in the bathroom, what they call the IPS panels, which are the pieces of formica that seal the pipes in, hadn't been sealed down the side with silicone, as you'd expect. So at that point, I wasn't entirely sure. I knew it wasn't right. I just wasn't sure of the extent of the problem. So I immediately contacted John Hood, who had expertise in kind of buildings, and Ian Powery, and we spent some time in the room just having a look round and finding out exactly what the problems were. And it seemed the consensus was that there was no HEPA filter. These rooms weren't sealed. I think John noticed. I think he may or may not at that point bought his smoke machine, which actually gives you a visual indication of the direction that the air is flowing in. At that point, I wasn't that clear on the validation in detail, but it seemed to me to be pretty unlikely that that room could have passed validation, given the fact that the airflows wouldn't have been appropriate because the room wasn't sealed and because there was no provision of HEPA filtered air to that room. And the integrity of the HEPA filter test is integral again to the validation of those rooms.
and this was in May 2015. Remind me when patients were not in the ward.
Patients were not in the Schiehallion ward at that point.
When did patients move into the
I
Schiehallion?
think it was 2 or 3 weeks later. 2 or 3 weeks later is my recollection,
two
but
or
I can't
three
remember the
weeks
exact
later.
date. So after finding the somewhat kind of surprising finding that the rooms didn't seem to have been built properly, I emailed Tom Walsh, the infection control manager, and I don't know whether it was the same day or if not, it was very soon the next day. We had the clinical teams were made aware of the problem. Grant Archibald, the chief operating officer, and David Loudon met with myself and Tom Walsh, where we kind of outlined what we'd find, and along with the advice I'd had from Ian Powery and John Hood about the rooms. There was then a meeting convened with myself, Tom Walsh, I think Brenda Gibson was there, Grant Archibald, I can't recall if John Hood was there, but he may well have been, and other senior managers to discuss the potential for the safety of moving patients into this unit. The consensus of the meeting was that in clinical terms, and I think it was Dr. Gibson that agreed to this, that she felt there was more risk leaving the patients behind in a standalone unit at York Hill than moving the patients to the bone marrow transplant unit. But she had actually built a pause into the transplant programme to take account of the fact that there was probably likely to be some disruption during the move. So there was no immediate transplant patients booked in at that time. But again, there should be minutes or notes of those meetings. And there'll certainly be notes of the email correspondence that Tom Walsh and I had with Grant Archibald, the clinical teams, and David Loudon around that time. The other thing at the meeting with Grant Archibald and David Loudon, I specifically asked, because the implication of finding the problems in these rooms in the Schiehallion unit was that the rooms of the same specification were built all over the rest of the tower block. in the adult unit and in the paediatric intensive care unit. So I think it was Anne-Marie.
Just give me that
sorry,
again.
yeah.
The implication of what you'd found in the Schiehallion unit was?
That possibly all of the rooms built to that design across the rest of the hospital site may have not been built appropriately. That includes the rooms in the paediatric build in the intensive care unit, but also the rooms in the adult build in the renal unit, the intensive care unit, and there was some in the high dependency unit from recollection. So it was a problem that potentially reached beyond the children's hospital to all of the rooms in the site.
And would the answer to that, Professor Williams, have been to say that the information you've been getting from the project team was clearly untrue, that validation had not happened because it couldn't have happened, and no patients were moving in anywhere until validation was carried out properly and evidenced?
Again, at that time of the meeting we held, the view was that the risk to the paediatric patients was greater if we didn't move them than if we did move them.
Sorry, give me that again.
Yeah, the meeting that we held to discuss specifically the move of the paediatric patients into the Schiehallion unit was that the risk was felt to be greater leaving the Schiehallion unit alone at the Oak Hill site than the move of the patients to the new unit.
That might be described as making the best of a very bad job.
It might, but I think the view was that these patients need a lot of additional input from specialities outside haematology. They would be dislocated then from that support, and the balance of risk was that they should be moved to the new building. Again, that wasn't a decision that I took, that was a decision taken at a meeting with Grant Archibald and clinical members of the haematology team.
I perhaps didn't give you the opportunity to respond to Mr. Connell's question, which I think was the effect that, at least on the basis of that visit to the Schiehallion unit, you must have appreciated that what you've been told repeatedly by the project unit, by the project team, was just not true.
Yes, it made it difficult for me to believe that the validation had been done. But at the meeting that I had with David Loudon and Grant Archibald to discuss this, I specifically asked David Loudon if he was aware of any problems with the adult bone marrow transplant unit, because obviously I drew the same conclusion that there may have been risks across the rest of the site, and was told in absolute terms that he was not aware of any concerns with the adult bone marrow transplant unit. So the problems with the rooms were limited to the special isolation rooms in the paediatric and the adult hospital, not to the adult bone marrow transplant unit at that point, as far as I was aware.
And that wasn't correct either.
That wasn't correct either. No.
I just wondering whether the answer to that might have been, well, I'll take that at face value, David, but can you show me the validation document for the adult BMT unit?
It could have been, but if you ask a senior colleague a specific question, then you have to respect their expertise, and if they give you a straightforward answer, then you have to accept that answer.
The way you described what David Loudon said to you was that he was not aware. Is that the wording he used? I mean, I appreciate it some time ago.
I can't remember the exact words. When I raised the possibility that there may be problems in the adult bone marrow transplant, he replied to the negative. I can't remember the exact form of words that he used.
We're jumping around a little in terms of time, but in dates. But if we can just look briefly at the document referred to on page 24, which is Bundle 27, Volume 3, page 161. This is slightly out of the order of the narrative you've helpfully given us in answer to His Lordship's questions, because the bit that you've dealt with there is a little later in your witness statement. We'll come back to that. But what we have here is you, I think, outlining problems with the BMT unit. Now that's the adult.
That's
BMT,
the adult BMT unit.
BMT unit.
So that document is after the problems with the adult BMT unit were identified by the implementation of our routine sampling in that unit.
Yeah. Can we just look on to the next page, please? And essentially what we then have there is a narrative description of what you saw the issues being, starting at the top by saying the outputs clearly specified the patient group was vulnerable to infection and therefore required the provision of a protected environment. And then there's a list of requirements and so on, which goes through this in some detail. And I think subsequently John Hood annotated that by adding his thoughts on it as well. Is that right?
He did, but that original specification rate dates back to that original 2009 clinical output specification that we discussed earlier. So the items in that were taken from the original output specification. That was the only document that had with any details of what was originally asked for in the adult bone marrow transplant unit.
I think you explained this to Mr. Connell, but can I just confirm, the document headed original specification was drafted by you with some input from Dr. Hood, or was it not?
The original document was drafted in 2009. I don't
Well,
know who it was drafted by.
I can see the clinical output specification was drafted in 2009.
Yeah.
But what we're looking at page 162, is that your summary?
That's my summary of the clinical output
with
specification.
input from Dr. Hood?
There was no additional input from Dr. Hood at that point. The
Sorry,
advice
no
from John
additional
Hood
input.
was basically taken at, it was taken from the original document. So at the bottom of the original clinical output specification, it said advice for this specification was sought from Dr. John Hood.
Thank you.
I think we can probably follow it through. If we go to 163, and then there's a list, current deficiencies identified, 2 rooms not HELPA filtered. There's a question about the rooms not being sealed, movement of ceiling tiles, air exchange is required to be over 12. That's probably why I mentioned that in the context of earlier questions. So you're not yet achieved. Sealed room, question mark, validation for leak testing. And then there's a comment about the particle counts in the pentamidine room, which has got a different issue, which we needn't take your time on. And essentially it comes to a conclusion at the bottom, which essentially means people are going to have to go back to the beats.
Yes.
And just so we can pick up what Dr. Hood does, if we go to 164, something appeared on my screen there and then disappeared again. Would it be 165? There we are. Thank you. And what we have is the same document into which Dr. Hood has interlined in red certain comments on various things. Is that right?
Yes, that's right. I think this is part of it's a partial email trail. So I think this comes from excuse me, an email that I sent round when I returned from leave to get the thoughts from all the infection control doctors and other interested stakeholders on the document that I was about to send to, I think it was for Jennifer Armstrong. And the reason for the document was not in any way an attempt to define a new standard for the adult bone marrow transplant unit. The reason for the document was to establish for a meeting with the contractor, I think it was later on that day or the next day, that in our view, we had provided a clinical output specification to them, which clearly outlined the fact that this would be for immunocompromised patients and that it should have been built to a similar standard for the West of Scotland. This wasn't an attempt to produce a detailed specification, which would have been utterly unreasonable in that time. It was really to start the process of discussion with the contractor as to how best we could start to rectify this situation. I don't know whether there was any concerns about, who was responsible or accountabilities and things like that. But I was asked specifically to provide a document relating to the clinical output specification, the passage through time, as far as I was aware, in terms of who'd assured people this was going on okay, and the deficiencies that had been identified at that time.
And it's because Dr. Hood has this information, it's he who chips in near the bottom of that page, a reference to the assistance of somebody called Andy Streifel, the
Yeah.
world expert in air quality,
Yeah.
at the time that the Beatson
Was
air,
built.
air arrangements were fixed. Is that right?
Yeah. And John Hood probably had the most expertise in Glasgow in terms of the built environment. I mean, Andy Streifel, I think, was a kind of world recognised authority on this. So he had, I think, direct dealings with Andy Streifel at the time of the development of the West Scotland Cancer Centre.
Okay, thank you. We can leave that document now. I just want to return to briefly to your witness statement to just get another couple of things out of the way. In paragraph 98, you've been asked to look at a set of minutes from 2014, but it's just because of my earlier questions about who the project team was. Because obviously the project team is a bunch of individuals. And in your witness statement, you say that you had reported at this meeting that you still hadn't heard from Fiona McCluskey. So she must have been in the project team, is that right?
That's right, yeah. This again relates to the timeline we discussed earlier, where we were informed in August 2014 that there was to be a change in patients coming to the hospital. At that point, that was when I asked for advice from the project team to compare the standards of the rooms that have been provided with the MDR-TB regulations, and I sent that email to Fiona McCluskey. That would, I think, from recollection, that would have been late August, early September. As of the 1st of December, I had not received a reply. So the escalation process is what we would normally do if we discussed it at the SMT. The action was that we'd try and resolve the problem by seeking expert advice from engineers. We hadn't actually had a reply back at that point, and basically we needed a reply to that specific query, and I escalated it at the Board Infection Control Committee at that point.
Yeah. And in fact, you record in that paragraph, perhaps more significantly on one view, that someone from the project team was effectively told to come to the AICC meetings to tell you face to face what the position was, and you were reassured again at a meeting that units were validated.
Yes, that's the AICC meeting that I referred to. I haven't seen the minutes of that meeting. I'm not aware of it being in the bundle, but that's my recollection. I'm sure it was an AICC meeting rather than a BICC meeting.
And you recorded in 99 that Dr. Armstrong had stated that the issues over MD-RTB patients and bone marrow transplant patients should be resolved prior to the opening of the new hospital. And you note, however, to do this, we needed to be provided with the validation certificate. So you were aware of that need, in advance of the hospital opening.
Yes, we were. I mean, this doesn't relate to the bone marrow transplant patients as such. This relates to the positive pressure lobbied ventilation rooms outside the bone marrow transplant unit. So again, the concern was that the patients were appropriately protected outside the bone marrow transplant unit.
So I can just make sure that I'm following paragraph 98. There's a reference to the Board Infection Control Committee meeting on the 1st of December 2014. And there you say, I commented. So you were present at that meeting?
Yes, I was, yes.
And you said you still hadn't heard from Fiona McCluskey. And from my recollection, one of the project team, I think it may have been Fiona, was asked to come to one of the AI, now that's the Acute Infection Control Committee
yes.
meetings. Now, is that a meeting that had happened before the board meeting on the 1st of December, or?
I can't remember, I'm sorry.
And we were reassured.
But again,
when you say we were reassured, what?
At that meeting, so I can only assume from the minute that the AICC meeting had happened prior to that board meeting.
So you were reassured at the board meeting?
At the AICC.
Sorry,
at the AICC.
At the AICC meeting. And you can't say whether that was before or after the board meeting?
I think looking at the minute, it sounds as though it was before, because again, it says we were reassured again. So I can only assume that the AICC had happened
Did
before
you
that date.
challenge that reassurance?
I think we'd asked the project team member to come specifically to provide an update of what was going on with the hospital, the validation and things like that. They came to the meeting and again restated that all the building was being done to the HTM 0301 standards. If that was the case, then there should have been no concerns.
It's just that your experience that year had.
That was
wait a minute.
That was prior.
No,
that was prior to any
December
problems. That was prior
2014.
to any problems being discovered.
Right. Thank you.
Well, I just noticed that at the time.
Yeah. We usually take an hour for lunch. Could I ask you to be back for 2 o'clock?
2 o'clock, yeah.